The idea of methadone is that it's long-acting as opposed to the short-acting opioids. It sits on the same receptor. It only has to be taken once a day, and by doing that, it will, with time, start to have its effects. And these are the effects we want it to have. It will relatively quickly eliminate withdrawal symptoms by substituting itself for the other opioid. As time goes by and the patient becomes stabilized on their dose of methadone, their craving for any of the other opioids should greatly diminish and then hopefully disappear.
I started using when I was 15 or 16, pills mostly, I guess, and sort of rapidly went into narcotic intravenous drug use. And by the time I was 18, I was addicted. So I was sick every morning, needed drugs, couldn't function. I was committing crimes to get drugs. I was convicted of a felony in the end. I think that's what really got me to think seriously about leaving Vermont and getting into treatment in New York.
When a patient is to start on methadone, they have to go to a methadone clinic. In big cities, such as New York and many of the cities in California, there are many methadone clinics. In some states, there are no methadone clinics, and in other states, there may be only a few. So this can often be a logistical impediment in terms of travel, but let's just stay with the big cities where there are usually multiple methadone clinics. Patients will start going usually every day, sometimes 6 days a week in the beginning. And they will probably have to do that for at least 3 or 4 months. If they do well, and again, that means that urines are negative for other drugs, and they attend the clinic and they're doing whatever else is requested, they will gradually get what are called take-home privileges, where let's say on a Saturday, they'll get a bottle to take home for Sunday. And then eventually on a Friday, maybe they'll get 2 bottles to take home. And eventually maybe they'll come once a week and get 6 bottles to take home. Currently, the maximum allowed take-homes is a 4-week supply in patients who have been stable in a methadone clinic for at least 2 years.
It's been life-changing. I don't know where I'd be if I didn't make that change. I would probably be incarcerated, or I may not even be alive at this point. I think it's the best thing I could have done. I was able to come down, get a job, go back to school, graduate with honors.
If you talk to opiate-addicted people and you ask them, what did it feel like the first time you used heroin or took an oxycodone, they will say things like, I thought the world was at peace. I felt like I was under a warm blanket. I felt like this is how all other people feel. I was not shy. In those people, I usually think when they're on methadone or buprenorphine, it's going to continue to do that, but in a formulation now that's not harmful to them, again, because of the long-acting nature of the medications.
When you first start taking methadone, there's not a euphoria to it. It's like relief, no withdrawal, no cravings, no sickness, just I felt normal.
I would say the single biggest misconception that has a very deleterious impact on both patients and significant others is that when a patient has been stabilized on methadone and they take their daily dose, and it doesn't matter if the dose is 40 milligrams or 120 milligrams, the dose is not important in that regard. If the urines are negative for other illegal or non-prescribed drugs, and hopefully they're using their time productively, they are not addicted to the methadone. They are physically dependent but not addicted. It is very important for the patient and their significant others to understand that physical dependence does not necessarily equal addiction. In the beginning, the significant others should also be getting a methadone 101 and an addiction 101 so that everybody can be on board. You know, I don't expect the rest of the world to understand methadone. And most of my patients, of course, don't disclose that they're on methadone to people at work or casual acquaintances. But I'm always hoping that at home, they can have peace with the methadone and not be constantly asked, when are you getting off of this stuff? Why are you still on it? It's not good for you. It's bad for you. Because people will say it damages your liver, it damages your heart, it damages your brain. None of that's true. But people will be told that over and over again. And often, when people go to mutual help groups and they go sincerely, they are afraid to disclose that they're on a medication, either in NA or AA, because they will be told, hey, this is not recovery. You are still on an opioid. You are still on a mind-altering drug. And again, this is not correct. They are physically dependent but not addicted to the methadone.
If I was 16, 17, 18 now, I would not waste time and everything else that occurred between age 18 and 26 when I finally got down here. I should have done it years earlier. I could have avoided felony convictions. Certainly you can avoid getting diseases. Why waste time and risk your life if you can get on something that's safe and you can get back to functioning normal?